Now it's brighter, it's better.
It's better. You can see me better now.
Yeah, was
good. Good evening, everybody. Welcome to Alafia. This is an Alafia charity organization, and this is an Alafia event. Alafia is an organization that discusses women and women's issues. Alafia likes to bring women together and talk about issues that are facing women. And for this evening, we have with us Dr. Ogonu with us, who will be talking about heart diseases and how heart diseases affect women and how women are suffering from heart disease. And let me give you a little background about our doctor here who will be talking to us this evening before she takes the center stage. Our doctor here, Dr. Ogonu, is a cardiologist from the Mid-Atlantic Pre-Med Group. She obtained her undergraduate degree from the University of Ibadan in Ibadan, Nigeria. Served a residency at the University of Connecticut Health Center in Farmington, Connecticut, and a fellowship at Beth and Israel at Beth, Israel Deaconess Medical Center and St. Elizabeth Medical Center, Howard Medical School in Boston, Massachusetts. She was an assistant professor of medicine at the University of Pittsburgh Medical Center and leads a group of specialized cardiologists in teaching cardiac rhythms and implantations of the pacemaker and defibrillator at various teaching hospitals in Nigeria. Our lovely doctor is married with 4 children and she lives in Maryland. And she's gonna, tonight, this evening, she's gonna educate us. She's gonna give us little nuggets of how, as women, we need to take care of ourselves, how we need to look at ourselves so that we will not suffer from heart disease, or even if we have heart disease, what we can do to minimize the impact of what that is gonna have on us and have on our life. And I'm gonna hand you over to our lovely doctor. And can we say hi for doctor? I hand over to you, ma'am.
Okay. Okay, thank you very much. I just wanted to, okay. Do you see me? Do you hear me? Yes, okay. So thank you very much. I just wanted to talk today. This is going to be very informal. I'm just going to talk overall about heart disease in women. February is a month that we talk about heart disease. And usually the first Friday in February, we have a Go Red for Women where we address women and heart disease in women. And you know, historically, it was thought that women didn't have a lot of heart disease, but we know that 1 in 3 women would actually have a problem with your heart and could die from heart disease or stroke-related issues. And we know that this particular statistics is actually, we are aware that more women will have death or cardiovascular mortality than all cancers combined. So if you include breast cancer, cervical cancer, lung cancer, all sorts of cancers, heart disease and stroke-related vascular issues still supersedes that in causing mortality in women. So again, this is extremely important. It's a very important topic. And nearly 80% of this heart disease can actually be prevented. So it is something that we have to be watchful for and identify it and respond to it early on in life. So the American Heart Association has been very involved in trying to educate and incentivize us to actually try to explore and identify heart disease in women so that we can address and treat it early in life. Some of the differences that we see with heart disease, you know, in the United States, most of the heart disease we have is related to coronary artery disease or vascular disease. And sometimes women present different from men. So the typical teaching that we get here about heart disease is that people have classical chest pain, crushing chest pain. But in women, heart disease in this sense can present a little bit differently. Women can have symptoms like only jaw pain, or even something as pain in their neck, pain on their left side, breast pain. And some women could be having a heart attack and the only thing they present with is just fatigue or feeling tired. So because of this, we try to educate physicians in training and physicians in the emergency room to be watchful that when women come in and have atypical symptoms, you should not discount it. You should still explore to make sure that they're not having a heart attack, because they can present absolutely different from men. The other thing is that sometimes women are often caregivers. So many times they don't think about themselves. And I have had patients who are my patients and they're male patients, and their wife comes in with them and they're talking to me about their husband, but then I can also see that they're also having issues, but they have essentially minimized their issues. So sometimes women present late because they're often taking care of other things around them. So by the time they come in, they're actually far advanced with their presentation of heart disease. So these are things that we should always be aware of. Presentation can be different, presentation can be late, and also historically, women have not always been treated the same way men are treated when they present with heart disease. When women come to the emergency room and say that they're having certain symptoms like palpitations, oftentimes it is attributed to anxiety, and they just tell you, well, just go and get some rest, everything is okay. And it's quite different from the way a man will be treated. A man, once they say they have symptoms, everything gets pulled out, but women, it's not unusual for us to be told that it's just a little bit of anxiety, it could be in your head, so just relax. So again, not only do they present late, they can present in an atypical fashion, and also their symptoms can be not well assessed by the caregiver. So these are things that we should all watch out for. In essence, we promote more research in cardiovascular disease in women because of all these features, because of the fact that it is often not identified adequately, and it's often not recognized enough to do the right thing. And so there's a lot of money put into research to look into heart disease and women. The other caveat that I'm going to bring in is also pregnancy and heart disease, because a lot of women may have high blood pressure that has not been diagnosed. Pregnancy and heart disease, they intersect in a very important way. So when people have high blood pressure before they get pregnant, or when they get high blood pressure during pregnancy, it's all intertwined with heart disease. And the other feature that I want to bring in here is also disparity. So not only is heart disease common in women, but also in Black women or women of minority heritage, Hispanic women, women of Native American women. Many times their risk of dying from heart disease is much higher than their Caucasian counterpart. And it's completely, I can underscore this when it comes to pregnancy and heart disease and women. African American women or women of minority descent have 5 times higher risk of dying from pregnancy, hypertension, and heart disease intertwined together. And even when you correct for, if you have a state where there's a high risk of dying, even when you correct for that and you correct for education level, you correct for socioeconomic level, African American women and women of minority descent are also at a much higher risk of having any kind of morbidity, mortality from pregnancy. So in essence, heart disease is extremely important in women. It needs to be recognized early. It can present in a very atypical fashion. It can also be minimized when people present. Women tend to not emphasize their symptoms. They tend to present late because often women are caregivers. So by the time they come in, they are much sicker. It also intersects with respect to pregnancy. And then finally, heart disease really underscores healthcare disparity, where women of minority, African-American women, Latinx women, and tend to have more risk than their Caucasian counterpart. So I'd like to open up the forum so that we can talk about questions and how you can essentially take care of yourself and people around you to help to minimize the risk of heart disease. So I hand back over to the moderator. You're on mute.
Thank you very much, Dr. Ngodo. You have really, really opened up the eyes. I know quite a lot of people. We have learned to know that women of ethnic minority, whether you're an African American, whether you're a Black, whether you are Hispanic, whether you're Native American, are more 5 times at risk of heart disease than our other counterparts. That's very, very interesting. And that's something that I know most people doesn't know. You've also talked about the historical thing, our treatments. Our treatments are different. If a man presents with certain symptoms, they will take the man seriously and every day will be pulled out to look after that man. While for a woman, they will say, just hold on a second.
In the UK for the first time, there's concerns that it may be more transmissible than the original virus and less likely to respond to vaccines.
Sorry about that. That's devices. Devices doing what they want to do, and the news is coming up when I didn't even exit and I don't even listen to this. Sorry about that, everybody. But we're gonna continue with that. And why is that? I have a question. Why is that when a woman will get to an hospital and give all the typical signs of having an heart attack, like what you said, just as a man would do, and doctors will decide to say, oh, it's in your head, because that is basically they're saying when they're saying you're anxious. They're saying that nothing is wrong with you, you're just anxious, go and take a rest. Why is that happening?
Yes, it's something that, studies have shown that when you, go into the emergency room and you assess the way women, one possibility is, number one, women present sometimes with atypical symptoms. So when we read about heart attacks in medical school, what we are told is that the classical symptom is chest pain, crushing chest pain. The person could be holding, they could be sweating. So that is already a known factor. Women, however, tend to present with atypical symptoms. So instead of having the crushing chest pain that a man would present with, they could have jaw pain, could be the only symptom they have. Sometimes they would have only fatigue, and they would just come in and say, I have shortness of breath or I have fatigue, and they could actually be having a real heart attack. So it is true that their symptoms could be atypical, so we have to open our eyes to think outside the box. But also, historically, we are just taking a little bit less seriously. And so that's why we have to educate people to say, don't assume that every woman that comes to the emergency room is anxious. You have to also be open-minded that they could have something organic and serious going on. It's just something that we've seen historically. So we have to keep educating people. And the American Heart Association is heavily invested in turning the cause of heart disease in women.
And another thing that is interesting when you're talking about emergency room and women presenting with the symptoms, I know that in the UK where I live, the first thing they would do in an emergency room is taking your obs, doing an observation, and then next to blood test, and blood test will get a lot of things, doing a blood gas very quickly to see what your numbers are doing, what your lactate is saying, what things like that are saying, the gas, what your blood gas is saying. And then they will look at your numbers, what your heart rate is doing, what your blood pressure is doing, what your pulse is doing. Do they not do those in America? They don't do all that kind of, at least do that kind quickly check this person, just a few minutes, you do the top to bottom check. And then before taking that decision, do they just, like as you talk about them, they'll just discuss with you, and then they will just say, oh, it's just like, you just need a rest. Even when you're saying I'm having this jaw pain or I'm tired all the time and things like that. Do they not just go do the numbers that will show certain things that are really going wrong and bringing the biological factors up?
Yes, so usually they will do the observation and bring you in and get all the, the vitals, the blood pressure, the heart rate, and then get an EKG. But sometimes heart disease may not present so classical. So the EKG could look normal, but you could still be having a heart attack. So if your symptoms are a little bit atypical, it could be easy to say, you know what, let's just watch for a few hours and then send the patient home. We also have data that suggests that if you have a man coming with chest pain and they're having a heart attack, and the woman coming with and having a heart attack, the man is likely to get a coronary angiogram and get a stent at a rate much higher than a woman, even though if you look at their enzymes or the blood work, it's equivalent. So men tend to get, again, the quick treatment, they get into the cath lab quickly, they get a stent, and they're good. The women, they're like, well, we're not sure, let's get a few more tests. So there's always that disconnect. And so we just tend to get less. That is just a historical, that's a known fact. And so sometimes when the woman comes to you, we've lost some time with respect to getting into the cath lab quickly. And so even though this other patient, you put in a stent and the heart muscle recovers completely, because we spent a lot more time trying to decide if this is real or maybe not real, by the time they get to the cath lab, they've already lost some of their heart muscle. So they start off a little disadvantaged, so to speak. Women also tend to get offered less coronary artery bypass. So sometimes if you have multiple vessel disease, the next best thing to do is to get an immediate open heart surgery. Women tend to be offered that as well, less. Women, it's true that women may have a little bit more obesity. Sometimes they also have a little bit more diabetes. So they're already coming at a disadvantage. They have a lot of metabolic issues going on. So it's just what we see. So you really have to be watchful for that. And women ourselves will have to take a lot of self-care so that we don't get to the point where we won't have to go to the emergency room.
Another question before I I'll let you go, the other speakers ask their question, is as you just touched on it, obesity and diabetes, because one thing that the British Heart Foundation, where I live in the UK, is really pushing is diet related and obesity. They keep on saying that obesity is one of the biggies for heart disease, coronary heart disease, is also for cancer, for the diabetes, and they're really pushing for diet for people. Is that really something that we really help women? Because as you're talking women, we are the caregivers, we're the one in the kitchen. We are the one that many times look after the family, preparing the diet, the food for the family. Will that be something that will also help us as we're giving good nutrition to our family, to be also giving ourselves those good nutrition?
Absolutely, that is a very good point. Obesity is a major risk factor. Obesity also intersects with diabetes, as you mentioned. So those are things that we should watch out for. So as we care for other people, we should also care for ourselves with respect to making sure that we are also eating the right food, the right diet, engaging in self-care, exercising, and just knowing that if we as the person who takes care of other people in the house are doing well and keeping healthy, then we're also in a better place to take care. But obesity is one of an incredibly big risk factor that we have. Some of our patients have obesity, they have sleep apnea, they have high blood pressure, they have diabetes, and all those things come together and intersect with presentation of heart disease in women.
Thank you. Now I'll hand you over if anybody else have anything to say. Any questions? Edlin, are there anything coming on from Facebook and YouTube? Are there any comments, any questions? I'm handing over to you right now. Oh, Evelyn is saying there are no direct questions. There are no questions on Facebook or on YouTube coming at the moment. But Doctor, I'm not gonna let you go because I was taking some notes and when you were giving your presentation, and it is quite interesting when you talk about this discrimination against minority, not only discrimination against minority, but discrimination against women in getting treatment early. It's quite something that is disturbing. Heart disease is completely different from anxiety, and it's so that the treatment is so minimized. The women doesn't get to the lab in time. Women and then for us, women of color, women of ethnic minority, 5 times. You talk about pregnancy, which means even younger women who will get pregnant are prone to having coronary heart disease or any of these things, and it could be missed. So what will you say to any young person that is getting ready to get pregnant or preparing their body as they're doing that? I know this time people are doing everything to get pregnant. They're watching how their body's doing, when to have sex, when the baby will come. Some people are going for fertility treatment. So what kind of an advice will you give to younger women that they will not be looking for all other things, but they will also be looking after their own health?
That's a very good question. Because pregnancy and heart disease really underscores the incredible healthcare disparity in the United States. This is one place where we have to educate our young women, to start early. We should educate them from teenage years to have heart healthy habits, to exercise, to reduce their risk of obesity, reduce their risk of smoking, reduce their risk of anything that will be considered unhealthy for them. And, the American College of Obstetrics and Gynecology, they look at the data that we have when it comes to pregnancy-related cardiovascular events like eclampsia, where, African-American women have 5 times risk of dying. I mean, the data is so staggering. And so they're looking at what are ways that we can do to reduce this. Because it's more than just, you have to educate, but you also have to have the support system in the community that is easily accessible to the young women, so that even as they get pregnant, they're getting care from day one through social services. Because some of them, they may get pregnant when they're very early, and you want to be able to get them in tune to taking care of themselves, getting their blood pressure checked, checking the urine for protein. But it's almost like a multidisciplinary approach. The data that I saw a recent data that showed that California went and they were very aggressive about trying to reduce the risk of perimortal and perinatal mortality in women, and they made a huge impact. But it was a multi-pronged approach where you educate the women youngly when they're very young, and you also give them access to all sorts of social services. Because really, it's a very unfortunate thing. Maternal mortality is one of the saddest things. So you have a young woman deliver a baby, and then the woman dies from eclampsia or from all kinds of illness. And as you can see too, with the COVID, the fact that COVID has really stricken the African-American community, the Native American community, the Asian American community, the Latin American community. You see how COVID has really decimated this population. And again, it's because of the disparity in healthcare, because we also have higher risk of hypertension, higher risk of diabetes, higher risk of obesity. And also many of the African Americans and Native Americans, they happen to be also frontline workers. So you add exposure to frontline work, and then all this disparity of care where they're already starting off with an extremely high blood pressure. And then COVID becomes almost a lethal exposure. So for the part that has to do with heart disease and pregnancy as it relates to extreme high maternal mortality, it's really something that has to be, it's a multi-faceted approach, but we have to educate people from when they're even very young. When I looked at some of the statistics a few weeks ago, I went to a conference and I listened to the statistics, and it's staggering. I mean, if you read the statistics, you wouldn't even want to get pregnant when you hear that you are 5 times more likely in spite of your educational level. So you're talking about PhD holders that are still at extreme high risk of dying because they had a baby compared to their white counterparts. It's very staggering information. But we have to have the information out there, educate young women. This is what you do. Start off healthy, get your blood pressure under control, lose weight. When you get pregnant, make sure that you're getting absolute care every single day so that at least you can do your own part and access all the resources that are available to you.
And also, I'm quite sure that with the internet and so many things about health issue going on, that will be one of the places that women should be doing the research, and as they're doing the research for other things about their life, about lifestyle, you should not be also doing the things of how to do your makeup nicely, how to do or how to look that size 6 or that size 8, because you want to diet, but you don't want to be too slim. That when you will also be in the same problem, you should also be checking about your heart, what your heart is doing. You should be also looking about your health. But one thing I want to ask, what about alcohol? Because these days, alcohol and cigarettes, smoking and alcohol and drinking, is it then also not a contributing factors? Isn't women also not should be cutting down on these things to actually look after our health?
Yes, that's a very good question. So the habits that we incorporate in life are very critical to what happens to our health down the road. So cigarette smoking, it's a huge risk factor for heart disease. It's also a big risk factor for vascular disease. And the interesting thing about vascular disease is that when you're a heavy smoker, sometimes not only does it affect your heart, it increases your risk of stroke, and it also increases your risk of having blockage in your legs. So we have a lot of young women, in their middle age or younger, in their 40s, 50s, heavy smokers. And if you combine it with diabetes, it leads to a lot of vascular disease where you're at risk of losing your limb. And also, when we talk about healthcare disparity, when you have critical limb or critical vascular disease in your legs, we are also, African Americans, minority patients are also at higher risk of having an amputation as opposed to a procedure to salvage the limb. So you start off with a disadvantage, you take up all these bad habits, no exercise, too much fast food, too much processed food, obesity, and then you start having pain in your legs when you walk. And then when you go to the physician, and if you have diabetes and you have a risk of gangrene, you're at risk of being offered amputation as an option, as opposed to something to salvage the limb. So that is something else that those habits are very important, that we avoid those kind of habits, smoking, drug use, and things that do not really affect your heart, your body positively.
Thank you very much, Doctor. We have been educated, I have been educated a bit about the American system, even though the British system is completely different. When you go into an emergency room, as far as I'm concerned, because I've worked in the emergency room, everybody you're treated at the same, and you try to give as best as possible, even though there is also some discrimination in treatment towards women and women's health, but they try as best as possible not to show that very big gap. And British Heart Foundation that is really looking after people with heart disease and bringing other things, they're really sending out the information out there in every area. They're doing the charity work, they're making sure information, and they're making sure that they're tackling the obesity. The government is fighting to tackle obesity. And because they know that once obesity is tackled, some of these things will be reversed. The diabetes and all the diseases that will lead to the stroke and the coronary diseases, they're encouraging people to go out and exercise, even though COVID have stopped most of these things. Because now that COVID has stopped most of these things, now that we are all basically in isolation, most of us are indoors. I know a lot of people that have not been out of those. Some people, because they're scared, they don't want to go out, they're scared of contracting COVID. They have been in isolation, especially women who have been isolated, and they depend probably on fast food. They depend on junk food because they can't get fresh food from the market, because they can't go out. Some of them are older, some of them are younger. They have other comorbidities that they've put them in isolation. And there, what advice can you give in a situation like this? What can these women be doing when they are lonely, they are isolating, they are home, they're not doing anything, you can't go out to exercise? What can they do in the home that will help them to enhance their own health?
Okay, that's a good question too. So with this period of COVID, as you mentioned, there's also isolation. Women are not seeking health care because everybody's postponing care. So sometimes we're encouraging our patients, if you're feeling not well, if you have palpitations, if you have chest pain, please seek care, go outside, go with your mask. That's number one. Please don't delay care. We have data now to show that a huge percentage of women have postponed their mammograms, which will have them out of sync with what they normally need to have. And they postpone their regular usual care like mammogram, pap smear, and things like that. So we encourage people, please don't postpone your care too much. Once the system is open, do that. That's number one. Number two, you can exercise at home. You can try to do, even if it's just a dance video at home, that's one option. so that you can move around. Don't sit around all day because it's not healthy for you. So you can exercise at home, go on YouTube, find a dance video, find some kind of exercise that you can do. Even if you do 10 to 15 minutes, that's good. Also, you can walk outside. We know that outside is a safer place than indoors. We don't just want to gather with people indoors. So walking outside and getting fresh air is something that we've encouraged people to do during this period of COVID. It's something that it's healthy for you. So go outside, walk outside, even if for 10, 15 minutes, ideally about 30, 45 minutes every, for about 3 to 4 times a week. But even if it's not that long, start somewhere and go a little bit at a time. Okay, so that's one. So exercise, walk, get good sleep because we know that good sleep helps your blood pressure stay down, helps you to lose weight. So I know that we're all stuck on the screen and many people are doing marathon on Netflix and Amazon trying to catch up on all the shows, but it's important that you get good sleep, get your 8 hours of sleep, and that will have you well rested. But exercise, even if it's indoor, preferably walk outside, get some fresh air, and get good sleep. And please don't postpone your critical screening care, like your mammogram, your pap smear, your blood pressure check. Try to keep up with all that care in this time of COVID. And of course, I'm encouraging all women. We have a big problem with vaccine hesitancy in the period of COVID vaccine. So I make a point to talk to my staff. Even some of the African-American nurses do not want to take the COVID vaccine. And so we have to keep educating our colleagues and our staff and our friends in church to say the COVID vaccine is safe. When it's your turn, please get the COVID vaccine. It doesn't matter if you get Pfizer, it doesn't matter if you get Moderna, and now we have J&J has been released, which will even be easier because it's only one shot. And don't worry about the percentages. You're still better off with a vaccine because next time you may get a different vaccine. You may get Pfizer next year. It's very clear that we're going to have a period where we're going to have vaccine. But please, when it's your turn, don't have vaccine hesitancy. If you have questions, talk to your healthcare provider, talk to a friend, talk to a sister, encourage women in your church, in your mosque, wherever your prayer house is, to please get the vaccine, because that is something that will keep you safe. So those are the points that I have regarding the COVID.
Thank you very much. Thank you very much, Dr. Ogundu. You have really, really educated us, and you've really given us an encouragement, especially in the area of people taking the vaccine. Because people have been taking flu vaccine, and influenza came, and because of it, they developed the flu vaccine, and people have been taking it religiously. Year after year, people have been willingly going to take it. But there's so much going around this COVID and the vaccine and issues that people now are scared. But so it's good that medical people like yourself are sitting there and encouraging us and telling us that it is safe, it's good to take, and we should also take them because it's better to have some protection than have no protection at all. And that's really, really, I want to thank you. But don't go stay around. There's another very interesting topic coming on that I'll be discussing and I'll be talking about with women. And I know it's affect mostly African women, especially West African women and East African women. I will be talking about female genital mutilation or cutting or female circumcision, as some people will want it to be called. That's the next topic that is coming on. So stay around because we will need your medical expert also to help us in that area, as I'll be talking about some of the things that will happen and some of the hazard and some of the risk that is happening ahead, especially for our young girls and for women in some of our West African countries that we have. But I want to once again thank you very much for educating us, for allowing us to learn some of these things, because some of these things are even new to myself, or some of the percentages, the discrimination and things like that. So I want to thank you very, very much. Well, people out there who are following us on Facebook, on YouTube, this is Alafia Charity. This is Alafia Wear events. They have an event that talks about women and things that concerns women, wherever you are in the world. If you're a woman, you can contact Alafia. Our details will come up in the screen, and you will see what Alafia is doing. Alafia talks about sickle cells. They talk about different kind of health issues related to women. They talk about things that also are concerning women. They talk about things like rape. They talk about education. They talk about nutrition. We even go in as talking about fashion. so that we will encourage women. And Alafia is where we pull the next sister up. You pull your sister with you and you take your sister along. You motivate your sister to go out there to get the indication, to get the information, so that they will not be left alone. That's why we're coming with these different people to give you the information. And as you're getting the information, pass it on to another sister. That will pass it on to another sister. And together, as we continue in unity, we will be able to kick against the men, because we're living in a male-dominated world that they look after themselves. They don't care about the women. They look after, they make sure everything for them is okay, and they look after. We have been living in a male world for centuries, and we've been kicking against it. We've been trying, we've been making headway, but we cannot keep silent. We need to keep pushing. We need to keep encouraging each other and taking each other along, so that our children, and when our children will have the information, and they will do better than what we have done, in the mighty name of Jesus. Well, brethren, I want to thank you once more for joining and for listening to this program. I have an interesting topic coming up, and it is called FGM, female genital mutilation, or female circumcision, or cutting, as you want to call it. I'll give you a bit of statistics, and then I'll tell you about myself and why I am talking about it. Because I can only be able to talk about it unless I give you my own background information, family information, where I am coming from in standing against FGM in that map. I'm going to use what most of the definition that WHO and other places are using, so that we will be able to say it's what it talks about. Female genital mutilation or circumcision involves the removing of parts of the external genital layer for non-medical reason. Simply, they go in and they remove your clitoris, probably remove even the lips, everything inside the vagina. They remove all of it for just non-medical reason, for just no reason. Basically, that's what it is saying. And most of this, and my focus is going to be on Sierra Leone. It will be on West Africa, that I know a bit, and it will also be in East Africa that I've had an opportunity to talk about, because it's a long time that I've been, since the early 90s, I've been kicking against FGM, but we have not been succeeding, but we're seeing a bit of success coming up right now. This is actually done by women who they call sewers. They get different names for them, but especially in Sierra Leone, it is done in a secret society called the Bondo Society. And these women, including my own grandmother, they had no medical training. They had no medical training on everything. And they can use anything from knife to scissors to pieces of glass to razor, anything. And this procedure is done without any anesthetic or anything that we will allow these women. Nothing, no anesthetic, no nothing. In fact, in some cases in Sierra Leone, these girls and at times women, they are held down. And the reason I'm talking about women, where I come from in Sierra Leone, you are always at risk of being snatched off in the street and taken to their society bush to join into their society, because probably you've talked against it, or probably they think that you're not one of them, and they have the way they call you, they have the way they will harm you. And if they have an opportunity to grab you wherever you are, how old you are, and take you, even family members will hunt you down because you're a woman, just for you to be involved, so that you will all be the same and you will all talk about the same. But what I want to tell people that it is not only demonic, it is also having a bad effect on women. As my name says, my name is Daphne Pange. I'm from the Pamende. I'm one of the Pamendes. I'm a descendant of the Pamendes in Sierra Leone, upcountry. Unfortunately, my descendants, they are all around the northern province, the southern province of Sierra Leone, from Bons to Moyamba to Rotofunk to Kenema in the eastern province, and to Kailaun. That's where they're spread. That's where my descendants are spread. My grandmother to my father called Miata. Unfortunately, when I was born, I was given a name. And as a baby, she needed me. She asked for me as a baby. Fortunately for me, my mother, who has an upper hand, asked a lot of questions. And as she was asking the questions, she realizes that something is not sitting right. Why do you want a young baby to visit. Why not visiting the baby? Why should the baby go into the village to visit when you can visit this young baby where the baby is? And there was problems, there was confusion around that and everything. But my dad, being who he is, who knew, who has been educated, who has been in the sciences and studying about sciences, who came to realize that female genital mutilation or circumcision is not something he wants for his girls, stood against them, he kicked against it because it was not in agreed. My grandmother was a Sowe who gave birth to my father. And he was not only just a Sowe who will have a bush. I have stories from my father that when it comes to the dry season between November and December in Sierra Leone, and my grandmother, from the 40s, the 50s, from the 30s, the 40s, the 50s, the 60s, will gather our girls up to the 70s. When she gathered our girls, all she needs to do is bring them to the edge of the ocean, brings them there, and they will disappear for about 3 months. What she does, our own society, our own female circumcision she was doing was being done underneath the waters, underneath the ocean. That's where a ceremony was done daily until she stopped when she get old. And I was unfortunately become the first granddaughter, and I was in line to inherit what she had. But as I said, my father was kicking and protecting us, but he doesn't have the upper hand. So regularly, they would call for me regularly. There would be regularly family confusion. But unfortunately for them, I was a rebel. I was a tomboy. I would never conform to the rules and regulations of a woman or as a girl that they needed. And fortunately for me, my uncles, they were younger. We were all like the same age groups. My cousins, they were all the same age group. So I have a lot of boys to grow up with. And growing up with boys, you need to learn their own things to survive. So I grew up like one of them. So I like growing up because I grew up with boys. By the time the other ladies, my cousins were coming, they were younger. They were quite young then, and so I could not grow up with them. So I had this struggle all my life. My father was there to protect, but the families was calling. I had uncles who will be coming up. I have auntie who will be saying, "You're not getting older. You're now a young woman. What have you done? We need you. Where have you not come there?" It got to a point where I visited my dad in the village because he was sick and everything. And I went and I visited him. And little did I know that I washed my clothes. I had some black skin ties, lovely skin ties, and I washed them and I hung them on. And little did I know that they were stolen. They were really stolen from these women, these Bondo women, these Sowes. My skin ties were stolen, but you know, you're in the village, you pack your things, you leave, you go. I get back home, you had many things, so you will not even recognize that things have been stolen. But they took these things, it took them into their bush and everything, and they were using them. My younger sister also went to visit dad and saw those things hanging drying. And he said, "Who are them?" And my dad said, "Oh, your sister came, but these women, they took these things, they are now using them." And she, being who she is, that they cannot, so why should they and everything? She took them. She took these skin tight, and these women were angry. She was caught. She was taken into their bush. They tried to do things to her. My father could not stop them. They tried, but being who we are our father's daughter, we don't comply, we don't conform to rules. She escaped. And we practically lost that our sister. Because the sister that I knew before that happened to her was not the sister that I knew anymore. Because it appears as if she has lost her mind. It appears as if she could not do anything else for herself. It was quite sad that even our own nieces, our own younger nieces and everything were wondering what's wrong. We could not put our finger on what was wrong with her. She became a changed woman. Just by her being snatched, taken into their bush, whatever was done with her, because my dad was a man, he was not allowed to go there. Even pleading, she had to escape. She could not tell us what happened to her, and that became our own fate until this day. And people have been suffering. There are people who will be speaking against them, and they have been suffering. There are times that I've gone to campaigns when we were talking about them, and we've been threatened that we'll be taken into the bush and we'll be caught. And nothing will come out of it. The progress have been made. Sierra Leone has made a progress. Now they put a ban that anybody under 18 cannot be cut. You have to give your consent for over 18. But what I'm saying is that is not enough, because these people don't wait for consent. And the thing about female genital mutilation or circumcision, as people want to call it, it is politically motivated. When it's time for election and elections are coming around, some of these politicians have the habit of sponsoring these always, giving them money, giving money to the paramount chiefs, and these people will gather these girls, whether you like it or not, they will gather these girls, take them into the bush, and they will want to circumcise them with or without their consent. Even with the law, there are places that it's still happening with even the law, with even the consent of an 18-year-old, they are still young girls who have been cut. There have been statistics that have shown that the young girls are still in the cut. And why is these people cutting in? Before they said it's a rite of passage. It's women who you're going out to your husband. It's where they will teach you how to behave to your husband. But that was years ago. These days, it has become commercialized. These women who are the sewers, that's their economic. That's what they do. That's how they get their money from. That's how they get their livelihood from. They don't want to leave it. Even when organization came up and they were going to give them money, they agreed that they took this money, but they were still practicing it. And even with a lot going on now, I don't know what they will be doing. But that's not all the political side. I want to leave it there. And another thing, just as my doctor was saying, about this thing about women being controlled, because it's all about control. Because the people who support this FGM and the community leaders and those traditional leaders and them, what they will say is essentially protect a woman's honor or her virginity or her sexuality. Why should a woman's sexuality or virginity be controlled? Or they will say, oh, if a woman doesn't undergo FGM, they will smell. On the contrary, women who have undergone FGM, some type of FGM, has problems with even controlling their urine. They are always urinating. They have fistula. They have all kinds of diseases that is affecting them. That even people doesn't want them to be around them because they are always smelling of urine. Also, their children, girls have died. Women, they have died. If you're a woman who had a sickle cell, a girl with sickle cell who has been cut, and these women doesn't know how to control those blood, to get control how to stop those bleeding, you bleed to death. And in Sierra Leone, they have the thing of saying that they open their eyes. They went there, they have eyes, and they've gone and opened their eyes. So what? You will not even get the body back to do a postmortem, to do an investigation to know why that girl died. Because they will say the girl died in their society bush, and they will bury that girl. Nobody has been demanding for those bodies so that a postmortem will be done, so that at least they will be educated that no, this girl didn't open that. They had underlying medical condition that has made them die. But not only death is there. If you're not dying and you're lucky, you come out of it, you will suffer things like hemorrhage, septicemia, tetanus, even HIV and AIDS due, because when they're cutting, they are not cutting and cleaning. There is one instrument they're cutting and moving and moving and moving and moving on and moving on from one person to the other, cutting without their instrument. Their instrument could be dirty, could be rusty, could be everything. And some of these women, they also experience shock. They are fearful, they have pain, they have trauma. There's difficulty in passing out urine, difficulty with menstruation. A ureter and the vaginal opening has been blocked. So how will they? Especially in the areas in the eastern part of Africa, the Horn of Africa, where they practice things like type 2 and type 3 kind of FGM, where everything is taken and then you're sticked up. It also leads to pelvic inflammation. And guys, they may suffer cysts, they may suffer abscesses, they may suffer ulcers. You are having all these health problems. Also, they even suffer in their education. Because of all the health problems, they are in and out of school. And some of them doesn't even finish school. They ended up, some of them will not go to secondary school. Some of them will either live in poverty also. The family are poor. They can't continue taking them to the hospital and school. So they will drop out from school. They become traders in the street. Some of them ended up not having anything. They are disadvantaged. Some of the people ended up being prostitutes and all things like that. And FGM also in many parts of Africa is the forerunner to child marriage, because they're rushing to get these children cut so that they would send them on into marriage. It comes again to pregnancy and childbirth. There's a lot of complication. Many women who have undergone FGM have had to have a cesarean section, or due to hemorrhage, due to postpartum hemorrhage. They've had difficulty in labor, they've had obstruction, the scar tissue, because the vagina, God made the vagina in such a way so that for childbirth there will be an easy access. When you cut it now and it's healed up, there is a scar tissue. When doing childbirth, the vagina should stretch so that the baby will come through, will not stretch. This woman will end up also with cuts, with tear and everything. And they will spend a long time in hospital, money and everything, that some, because of poverty, they don't have it. And with all of those complications, they will end up dying and leaving young babies. And also they suffer from mental health problems. Studies have shown that girls and women who have undergone FGM are more likely to have post-traumatic stress disorder, anxious disorder, depression. They have physical complaints, they are aching and pain, but you don't have any organic reasons for it. They go to hospital, but there is none. But people try to normalize it. They said, oh, it's our tradition, it's religion, and this and that. It is not. It is a violation of human rights, a violation of that child's right, a violation of that woman's right, and the trauma that is associated with it. There's a lot of problem about the health, the mental health, and the well-being of women who have undergone FGM. There's a lot of statistics out there. There's a lot. And the thing is, there's so much secrecy. For the UK, there was a law passed for 30 good years. And in that 30 good years, it was only in 2014 that they had one conviction. One conviction. And the only reason they were able to have that one conviction was because she decided to do the FGM in the UK. And this girl, whatever they did, ended up with so much trauma, so much bleeding, they could not contain it. They had to take her to hospital. And they went and concocted a story, but the doctors there knew that something was wrong, so they involved the police. And that ended up in one conviction. Because there is a law that if you find out, and they have, and there's quite a lot. They are trying, the government, the social worker in the UK, they tried. When it comes to Christmas time, they will ask questions. When girls are going into holiday, they try teaching children. But there's a lot that needs to be done. We need to keep pushing it out there. We need to keep talking about it. If nothing else, just because of the health issues that he has. And I'm going to stop there for now, and I'm going to see if there's any comments, any questions. Doctor, if you have anything to add, can you just, from the medical side, can you just tell us a little bit? I know you will know a little bit about FGM. Can you just give us a little gist about that?
Well, thank you for that question. And yes, because I did my medical school in Nigeria, I am aware of this practice, and it was something that during our OBGYN fellowship or training, it was called to our mind that this is a practice that is not medically beneficial to the young women. And so multiple times we did projects in the rural areas of where I did my medical school, and we would deal with female genital mutilation, but also we had young women who were really, for some of them, they either had this problem or they also had the problem of premature pregnancy, where they're extremely young. And so when they're extremely young, they're not developed for pregnancy and for childbirth. And so when these young teenagers who have narrow pelvis, when they go into labor, they're in labor for many, many, many hours. And ultimately, they have something that we saw commonly in the northern part of the country called CPD, or cephalopelvic disproportion. And what we saw was that some of the women who had this problem also had genital mutilation as well. So it was a double whammy that made these young women have a very difficult time with the pregnancy. And then during labor, it was very long. And what they would have is they would have a necrosis, or the tissue around that area eventually becomes necrotic and the tissue dies. so that after the pregnancy, if they survive it, if they survive the delivery, between the genital mutilation and the cephalopelvic disproportion, if they survive it, then they're left with all sorts of fistula where they are leaking both urine and sometimes feces as well. So not only have they gone through the mutilation, they've gone through pregnancy where they're too young to handle the pregnancy and the delivery, and now they have an outcome that makes them become an outcast. So this is really a cause that sets these women up for really a terrible cause in their adulthood, because they've had the mutilation, then they had a premature marriage and pregnancy, difficult delivery, cephalopelvic disproportion. Now they have both vaginal and rectal fistula where they leak all sorts of things from that area. So then they become outcasts. So this is something that we see in young women. So I really think that your platform is bringing to light something that is very important and that we should continue to have conversations about, both here and also in many parts of the African countries, especially Nigeria.
Thank you. Any comments, any questions from our viewers, from our listeners? Oh, well, I think the people listening, they are actually digesting what has been said here tonight. They're taking them in. And Alafia, as we have discussed these two issues that we'll discuss here today. If anybody you need any counseling, especially around the area of FGM, or you need more information about what to do, you think you're suffering from heart disease, or you have a family member or stroke or diabetes, or you need some little nuggets about some health issues, I'm sure doctor will make available. She will have some little advice to give. If anybody, I know that some people probably want to ask a question or you want to make a comment, but you're too scared, or it's personal to you. Alafia is a platform we will stay and you can access. We will be able to counsel, we'll be able to give advice, or we can also be able to direct you to go where to go to get help, because there's quite a lot of organization that will give help, whether it's health, whether it's that kind of thing, or you have a young child, you don't know, you're under pressure to send that child to Africa, or even where you are, because they are doing it even in where we live in, there are people doing it. And even when medical doctors, some people are saying, no, they can do it medically, but for what benefits? So you can ask the questions. If you don't know who to turn to, if you turn to us, we will direct you to the right people who will give you protection of how that you could secure your girls. You can even start talking to them, because there are other people who go out and talk to them and they will call them names. Oh, you're not part of us. In Thailand, they will call them your boka, meaning you're not part of the Bondo society. And if you're not part of us, you're not clean. You're not clean. You can smell. You're dirty or whatever. You could be free. You could go into prostitution. But there's so many things that has happened to these women that women have been talking about. That I talk about. It's been all over the internet. People are talking about it. People are making noise about it, and we will want it to continue so that everybody will have the message, so that this harmful and historical barbaric practice will stop around our girls. And also, a lasting thing that for all women, our health, exercise, nutrition, look at what we are eating, exercise, and let's look at ourselves. We have no excuse to say it's COVID. We are in isolation. We cannot exercise. If you can't go out for a 15-minute walk, a 10-minute walk, and then come back in, do those stretches, find those dance moves on YouTube and dance yourself to sweat, and then you can go and have a nice thing. Women, we should be each other's keeper. We should be looking after each other. And we were coming to the end of the program. Once more, thank you very much, Doctor. You've not only told us, you've even expanded some of the health reasons about female genital mutilation. What some of these young girls, those girls that will go into early marriages, not only have they been mutilated, they've gone into an early marriage, they've now had a pregnancy before their bodies develop for that pregnancy, and during long labor, they are also suffering, having their pelvis out of the way, having fistula, leaking urine, leaking feces. We hope that this message will go out there and the right people will hear them, and women that we are having the children, mothers we will try as best as possible, whether in poverty or whether our economical situation, to protect our girls from female genital mutilation. This is your host, Daphne Pange, and I want to say thank you all that has been listening to us. God will richly bless you. This will be a week of blessings, a week of favor, a week of new things into your lives in the mighty name of Jesus. Bye, and thanks once more. Thanks very much, Doctor. I appreciate it coming on. Bye. Good night.
Good night.